Hello everyone, this is Lide Chartalastroy for the Global Environmental Health class in Spring 2025 at NYU. Today I want to take you on a journey, not just through the biology of a disease, but through the lived reality of a community fighting it. We'll briefly look at what causes and spreads cholera, identify key symptoms and disease timeline, explore its global and social impact, review prevention and treatment strategies, and then examine a real-world response in Kayole, Kenya. Cholera is a severe diarrheal disease caused by Vibrio cholerae in contaminated food or water. It leads to dehydration and can be fatal without treatment. Most cases respond to oral rehydration salts, while severe ones may need IV fluids and antibiotics. It spreads fastest in underserved areas with limited healthcare. Oral cholera vaccines help prevent outbreaks in high-risk communities. Cholera spreads via the fecal-oral route through contaminated food or water. Safe water, sanitation, and hygiene are key to prevention, highlighting deep social and economic inequalities. Cholera has been known for centuries, but its global impact emerged in the 19th century. Six major pandemics during the 19th and the 20th centuries caused millions of deaths, and the ongoing seventh pandemic began in South Asia in 1961 and it's still going on. Contributing factors for this disease include conflict, displacement of population, climate-related events, as well as insufficient investment in maintaining and upgrading wash infrastructure and services. The number of cholera cases reported to WHO has continued to rise in recent years. In 2023, more than 500,000 cases and more than 4,000 deaths were reported to WHO from 45 countries. Thus, these numbers are probably even higher. Stigma, trade impact, or poor surveillance keep cases hidden. And as we can see in figure number 1, most of the cases and countries with higher mortality rates are predominantly in Africa. For cholera, the solution lies in the basics: clean water, safe toilets, and regular hand washing, the wash essentials. These are things most people use every day without thinking, yet millions still live without them. With these simple measures in place, cholera becomes a fully preventable disease. After a decline in cholera cases after the 90s due to improved public health measures, better sanitation, and vaccination efforts, the disease began to resurge in the 2010s. This increase was driven by humanitarian crises, conflicts, and climate-related disasters in countries with weakened infrastructure. While the COVID-19 pandemic led to a temporary decline in cholera cases in 2020-2021 due to travel restrictions, hygiene measures, and reduced human mobility, it also disrupted public health systems, hindering cholera prevention and treatment efforts. As COVID-19 restrictions eased, cholera reemerged in 2022-2023, fueled by ongoing crises and insufficient healthcare responses. In 2023, 63.8% of the cases happened in African countries, as we can see in Figure 3. These graphs show us the burden in endemic countries. Pause a moment and take a look. Most of the countries are in Africa or Asia. The incidence rate, that is the blue line in the screen, varies across African countries, but see that the case fatality rate percentage, the red line, is always higher in every African country. The death tolls are higher in Africa. In Kenya, cholera has been a persistent issue, with outbreaks occurring regularly. Major outbreaks were reported in 2015, 16, 19, and late 2022 and early 2023. The disease is widespread, affecting 68% of Kenya's counties between 2015 and 2023. Despite challenges, Kenya is striving for cholera elimination by 2030 with increased vaccine campaigns and efforts to improve water supply and sanitation. But let's zoom into Kayole, a case study to better understand approaches to intervention. Kayole is a neighborhood in Nairobi, Kenya, where the outbreaks have more tolls. It's a dense, low-income area with many informal settlements. People live in close quarters, unemployment is high, and many survive on less than $1 a day. Access to toilets is limited, clean water is expensive, and health services are stretched thin. This is a perfect storm for a cholera outbreak. But why the outbreaks happen in places like this? Water comes from unregulated sources, often contaminated. Sanitation infrastructure is weak, with open defecation being common. Overcrowding means the disease spread fast, and weak surveillance delays the response. To curb cholera, several quick interventions were deployed in Cayole. Community health volunteers promoted hygiene door to door. Water points were chlorinated, hygiene kits distributed, and public toilets cleaned. Cayole Level 4 Hospital improved case management and awareness campaigns were launched. But response had limits. Community health volunteers were faced burnout. Soap was used to wash clothes and not hands, and waste collection remained inconsistent. Clinics lacked the staff and medicine, and people understood what was needed, but the thing is that they lacked the resources to sustain it. So here is what Cayole taught us. Community health volunteers are essential. They are passionate, amazing people willing to help but need support and resources. Quick fixes help, but without long-term wash improvements, cholera comes back. Hospitals need strong surveillance, logistic, and supply chains. Health education only works if people actually have the resources. Health is tied to housing, sanitation, and poverty. So cross collaboration is key. So, in conclusion, cholera is not just a bacterial disease, it's a reflection of injustice. It tells us exactly where we need to do better and who's been left behind. Cayole showed us that even in crisis, communities stepped up. They organize, they educate, they act, but they can't and shouldn't do it alone. To end cholera, we need more than medicine. We need systems that work, support that last, and the political will to make clean water and safe homes a human right. Thank you so much.